Hi, good evening, friends. My name is Pankaj Arora and I'm certified in clinical sleep health, RPSGT and pediatric sleep batch. I'm co-author of Understanding Polysomnography and RPSGT Pulse. I work for a company called Somnomedics as a country manager and for India and subcontinent. So today I'm going to speak on polysomnography and its report and interpretation. So objective of this session is to look at different parameters used in PSC report and their interpretation. So what happened when you do a polysomnography? You put a lot of sensors. You get because you want to get a lot of physiological data from the patient. So you put pulse oximeter, you put thermistor, you need to put effort belts, you need to put a pressure transducer, you need to put snoring microphone, you need to put leg movement sensors, you need to put EEG for getting the different sleep stages, you need to put a body position sensor, you need to put you need to have a video, you need to put a blood pressure, CO2. So a lot of sensors you put on the on the patient because you want to have some kind of a data which will be shown in this kind of a raw data form, which is called as an epoch. So but this is only one epoch where you are showing, yes, where you are seeing different a lot of waveforms, but this is only one page. In whole 8 hours of study or 7 to 8 hours of study, you get more than 1,000 pages of like this. So you need to score this data. You need to evaluate this data and then comprehend into a report format so that it is easy to understand for a patient and easy to understand for a clinician who has sent you the patient for a sleep study. So now we are going to look today what are the report parameters of the polysomnography and what is the interpretation of it. So what is sleep report? So the patient has come to you for sleep study because he was feeling lethargic during the day, he was feeling tired during the day, he was not able to work at the optimum level in the day, and that is why he has come to the sleep lab. So it means his sleep was fragmented. So we need to look at how the patient is sleeping during the night, and that is why we are interested in the sleep report. So before I jump directly to the report, how the report looks like, I would like to tell you what is the normal sleep architecture of a normal person. So what happens when a patient tries to sleep? He enters into sleep through non-REM stage. It means he is entering into sleep stage through, which is called as stage N1. Then he will jump to N2, that is stage N2, and then he will go into deeper stage, that is called as N3 stage, and then he will jump to REM state, that is called as rapid eye movement stage. So this will take approximately 90 to 110 minutes for completing this cycle. And this cycle, so this kind of a cycle happens 4 to 5 times in night or each night. So out of this whole night, the total sleep time, for example, this N2 comprises the most sleep stage. It comprises at least 45 to 50% of the total sleep time in the whole night. N1 takes around 5 to 10%, and 3 around 20 to 25%. Similarly, RAM also take around 20 to 25%. Now I will take to the sleep hypnogram of a normal adult, which looks like this. So this is, if you see it, this is 8 hours of study, 8 hours of sleep, where you can see, where you will appreciate the patient was awake and then went into N1 and then to N2, and then he was for a longer time into N3, then he came back to REM, and then he jumped back to N2, and then he came back to N3, and then he was again longer for N3. And this cycle, so we can appreciate that during first half of the night, the patient was spending more time in stage N3. But when the patient moves to the second half of the night, you can see the patient is spending more time on the REM stage. But overall, his stage N2 will be the most total sleep out of the total sleep time. So now, before still I jump to the report, I would love to give you a few definitions. So what do you mean by total recording time, time in bed, and total sleep time? As the name itself says, total recording time means when you start the polysomnography unit, means when you switch on the polysomnography unit and when you switch off the polysomnography unit back, so this is the recording time, that this is total recording time of the polysomnography. But we are mainly interested in time in bed. Why we are interested in time in bed, we will come to know in the subsequent slides. So time in bed is defined from the lights off to the lights on time. So it means we have prepared the patient, we have woke up the patient. Now we are telling the patient, please go to the bed, try to sleep, and we are switching the lights off of your room. And actually, we are giving the software also that we are defining the lights off. So it means when we tell the patient to sleep, when try to sleep and switch off the lights, that is called as lights off. And in the morning, when we wake the patient up and define and turn the lights on and also give the software lights on, so that is the time between lights off and lights on is time in bed. So that is what we are interested in. And we want to know how much time he has slept between lights off and lights on. That is called as total sleep time. He has slept between lights off and lights on. So now what is sleep onset and sleep latency? So sleep onset is, for example, the patient is, we put the lights off at 9 p.m. and tell the patient to try to sleep. And the patient sleeps at 9:20 p.m. So we define lights off at 9 p.m. Patient sleeps at 9:20 p.m. So it took him 20 minutes to sleep. So that is called as sleep latency. So how much time it took from the lights off to the first epoch of the sleep, that is called as sleep latency. And at 9:20 p.m. is called as sleep onset. So sleep onset is the time where the first epoch of sleep comes, and how much time it took from the lights off to the first stage of sleep is called as sleep latency. Okay. Similarly, what is REM latency? REM latency is the time from the first stage of the sleep, from the sleep onset to the REM onset. That is called as REM latency. For example, we define lights off at 9 p.m. He slept at 9:20 p.m. But his REM stage come at 10:30 p.m. So from 9:20 till 10:30 p.m. is 1 hour and 10 minutes. So 1 hour 10 minutes means 80 minutes. So his REM latency was 80 minutes in this particular case, as an example which I'm trying to give you. But in normal cases, REM latency is between 90 to 110 minutes. Okay, so now I'll come to know, I will tell you total sleep time and sleep period time, which will explain you with this graph, which gives you. So I told you, starting from the polysomnography unit and switching of the polysomnography is the total recording time. Defining from lights off to the lights on is basically time in bed. And from the first sleep stage, from the sleep onset to the last wake stage, stage is called as sleep period time. It also includes wake time in between. So again, repeating, from the first sleep stage to the end wake stage is called as sleep period time, while total sleep time is only total sleep time without the wake time. So you see, we defined lights off at 9 p.m. Patient slept at 9:20 p.m. So starting from 9:20, and for example, patient wakes up at 6 a.m. So from 9:20 p.m. till 6 a.m. is the whatever time he has slept is total sleep time. We are not interested if he has woken up for 20 minutes, 30 minutes in between. That is called as VASO. Wake after sleep onset. So now we will able to appreciate the difference between sleep period time and total sleep time. So total sleep time is only sleep time without wake. SPT, that is sleep period time, consists of wake also. So why we are defined, but why I was trying to tell you the sleep latency and sleep onset, because our lights off and lights on, because we are interested in sleep efficiency. So what will happen in the normal person? Sleep efficiency is 85 to 90%. But what will happen with the patient who has sleep disorders issues? will have different sleep, will have low sleep efficiency as compared to the normal person. So how do you define sleep efficiency? Sleep efficiency is defined by total sleep time. We know what is total sleep time. So total sleep time upon time in bed into 100 is total sleep efficiency. So for example, total person has slept for 100 minutes. That is total sleep time. And time in bed, he was there in bed from lights off to lights on for 200 minutes. So 100 by 200 into 100 by 200 is 50. So it's 0.5 into 100, 50% was the sleep efficiency. So in this particular case, as an example, 50% was the sleep efficiency because he slept for 100 minutes, but his time in bed was 200 minutes. So how do we define sustained sleep efficiency? Sustained sleep efficiency will be defined as total sleep time upon time in bed minus sleep latency stage 1. So for example, I told you the same case, total sleep time, he slept for 100 minutes. His time in bed was 200 minutes, but his sleep latency was 20 minutes. So now it will be 100 by 180 into 100. So now sustained sleep efficiency will be 55%. So please remember, sustained sleep efficiency will be always higher than the sleep efficiency. So now this is how the sleep report looks like. It will show you recorded time. Recorded time in this case was 11 hours, but time in bed when we switched the lights off and told the patient to sleep was much less. And this is 10 hours and 28 minutes and 27 seconds. So in this particular case, you see this is the kind of a sleep hypnogram. If you will see it and you will appreciate that the patient is in mostly in N2 stage, which I told you that patient actually out of total stages, N2 stage comprises most of time. Should be 45 to 50%, but it's in this particular case, if you see this graph or if you see this thing, it is more than 50%. It is 67.5% in this particular case. And you will also appreciate that I told you that in the first half of the epoch, night, N3 stage covers the most, but in here we can see there is no N3 stage, and that is the reason it is showing you only 2.5% of time in bed total. So this is how we will come to know that this person was mostly in stage N2 and not in or N1, but not in N3. So probably he was feeling lethargic because he was not going to N3, and because of whatever issues, he was not able to go to the stage N3. So in this particular case, total sleep time is 9 hours 31 minutes because he slept for 9 hours 30 minutes. So his sleep efficiency was 90%. How do you calculate sleep efficiency? I told you total sleep time is divide by time in bed. So total sleep time in this case is, if you calculate 9 hours and 31 minutes, is come to 9 into 60 is 540 in plus 30, 571 minutes divided by 628 minutes, which will come to 90%. So sustained sleep efficiency will be higher because in this particular case, 571 minutes minus it is case of 628, because you need to 628 minus 2 is 626. So you need to see the sustained sleep efficiency is higher because you need to subtract the sleep latency from the total time in bed. I hope it's clear. So it is also giving you sleep latency, how much time it took from the lights off to the sleep onset, which is giving you sleep latency, which is less in this case, 12.5 minutes. I told you it is generally 15 to 20 minutes. It's in this case, it's showing you 12 minutes and it's showing you sleep latency. And similarly, it will show you when the patient went to REM latency, because and then our interest is also in the VASO, that is wake after sleep onset. How many times patient has woken up? How many times patient has woken up after the sleep onset? So in this particular case, this 53 minutes, yes, this patient has woken up in this particular case. And if you also see, his total light sleep comprises, that is stage N1 and N2, is 7 hours and 29 minutes, while deep sleep was only 15 minutes. So the patient is obviously not getting non-restorative sleep, because N3 sleep is called as restorative sleep, so he's not getting that non-restorative sleep probably, and this could be the reason that he is feeling lethargic during the night. But obviously we'll see in the next slides what is the reason. So now coming to the after the sleep report, we'll look into the respiratory report. So before I jump to the respiratory report, I would love to tell you what is respiratory report consists of. So what we are interested is especially in sleep disorder breathing, we are interested in the patient could be having an obstructive sleep apnea, patient could be having a central sleep apnea, patient could be having a mixed sleep apnea, and patient could be having a hypoapnea. So what is apnea? What is obstructive sleep apnea? In this particular case, obstructive sleep apnea is just in simple terms. When there is a windpipe, there is a trachea which is completely blocked, then there is no air going to the lungs, and that is called as obstructive sleep apnea. When there is a partial opening of the airway, then it is called as hypoapnea because the partial air is going with the help. But hypoapnea is done that it is, for example, the air was going as a it was 100 volume of 100 ml and now it is going at 70 ml. So with 30% reduction in the volume, but with the desaturation of 3%, it is called as hypoapnea. And obstructive apnea, I already told you, complete cessation of flow. So then you need to calculate total number of obstructive apneas, total number of hypoapneas, and total number of central apneas. So what is central apneas? When your neuro does not send a signal to your body to breathe itself, that is called as central apnea. So you need to calculate obstructive sleep apneas. You need to see obstructive total number of hypoapneas. You need to see at central apneas, and you need to look at mixed apneas. You need to add all these things, all these apneas, divide by total sleep time, multiplied by 60, which will give you an index of apnea hypoapnea index. But we are mainly interested also in AHI, but also in the respiratory disturbance index. So what is respiratory disturbance index? Respiratory disturbance index is all total number of apneas, which I told you, plus RERAs and flow limitations. Plus RERAs and flow limitations multiplied by 60 total divided by total sleep time is called as respiratory disturbance index and not respiratory desaturation index. So now, how will this report looks like? This will give you obstructive numbers, total number of, for example, in this case, you can see total number of obstructive apneas happened 283, mixed were 245, central was 38, undefined apneas was 2, and total. So you add these all this, it comes to 568, and you add hypoapneas of 324, which comes to 892. That is apneas plus hypoapneas was giving 892 and index of 99.7. But if you add limitations and RERAs, which comes to 901, which is index of 100.7, which is very high. So he's a kind of a severe obstructive sleep apnea case. So but one thing I would like to tell you, what do you mean by undefined apneas? So undefined apneas are nothing but when the sleep technologist or a doctor does not able to score or does not able to justify whether it's obstructive sleep apnea or central sleep apnea, because probably the effort signals were not coming proper, but obviously there was a nadir in the flow channel. So it means there was an apnea, but we cannot define whether it's an obstructive sleep apnea or a central sleep apnea. So we define it as an undefined apnea. So at least it will be calculated, it will be subjected to a total apnea hypoapnea, and then we will able to come to know the exact apnea hypoapnea index or respiratory disturbance index. It will also give you a report will also give you a whether it's happening during REM stage or a non-REM stage. So you can actually say whether it's a REM dominated obstructive sleep apnea or a non-REM dominated obstructive sleep apnea. So another is, it is also giving you the complete report of respiratory, also gives you whether it is happening during supine position or a non-supine position, that is supine position or a lateral position. Why it is useful? It is very useful in particularly when the patient is having mild to moderate obstructive sleep apnea. Because what is happening, for just an example, if he is having a apnea hypoapnea index of, for example, 12 or 13. So, but his most apneas or hypoapneas have come during supine stage and not have come in the lateral stage, lateral positions. So So we can, as a clinicians, we can tell the patient, try sleeping on a lateral position and probably your apneas and hypopneas will not appear, because most of his apneas and hypopneas were coming in the supine position that I told you and in my example. So this will help. Positional apneas will especially help during mild to moderate cases of obstructive sleep apnea. So now again, respiratory analysis continued. If you, this will also show you in the graphical display. Graphical display in the first scan itself, you will able to know whether he is having more obstructive sleep apneas or more hypoapneas or mixed apneas, and for how many times. For example, for if you look at this bar, most of his obstructive sleep apnea is happening between 15 to 30 seconds. So you will come to know this obstructive sleep apnea or hypopnea was happening between 15 to 30 seconds mostly, and not at 45 to 60 seconds like here it's showing you nil. However, most of his obstructive sleep apneas or hypopneas, central apneas are happening between 15 to 30 seconds. And then he is getting aroused always. So now look at the SpO2 report. So what is happening because of obstructions happening and because the flow or air is not able to go to the lungs? So it will obviously affect the affect one SpO2, also affect the oxygen saturation. So we should know how much oxygen saturation or oxygen desaturation has happened during the sleep stages. So in this particular cases, if you see, in this particular case, if you see, his number of desaturations happened 929 times. That means 100, it has an index of 103. It is severe obstruct or severe ODI, that is severe oxygen desaturation index. His minimal SpO2 was 55 at 1237. However, his baseline SpO2 was 92. So his average SpO2 was 83%. And 927 times or 70% of the time his oxygen desaturation was below 90%, and 55% of the times his desaturation was below 80%. So it gives you a fair idea that how the oxygen desaturation has gone during the whole night. So this gives you clear indication. This gives you clear table format as well as a graphical format. It also gives you a sleep. It also gives you a whether SpO2 was more going into desaturation into a REM stage or non-REM stage. So it gives you a clear, complete snapshot of SpO2 report. Now, spindle. Why spindle report is important? Because what will happen, sometimes you take a lot of medications. Sometimes patient is having taking some kind of medication, especially during depression or during insomnia. So these medication can cause more spindles. So what is basically spindle? Spindle basically is happening. Spindle basically is happening in the is a criteria of marking stage N2. So in stage N2, you will get a lot of spindles as well as K complexes, and that is how you mark stage N2. But like in this particular epoch, if you can see, you see this spindle, which is having a frequency. Spindle has a frequency between 12 to 14 hertz. Here you can see it's showing the frequency of 13.6 hertz. So it is a complete, it is a spindle obviously, and this is stage N2. So in this particular spindle report, if you see, yes, agreed. In mostly, it has to appear in N2 stage. So 332 spindles or 138 of index is happening during stage N2. But if you see, spindles are appearing during sleep deep stage, that is N3. If you see, deep stage are anyways very less, but 170 deep stage spindles are coming during this deep stage, stage N3, which with an index of 118, which it means patient is taking either some kind of a medications. Because of this, spindles are coming also in stage N3 or any other stage. So we need to look into it. If the patient is taking some kind of medications, and because it is, and it, in turn, it is affecting the spindle report. So now, as I told you, when the patient is having sleep disorder, breathing issues, or sleep disorders, breathing issues or sleep disorders, and having obstructive sleep apnea, or hypopnea, it will obviously have desaturations, which will affect his heart health also. So we need to look at how his heart is behaving, how his heart rate is behaving. So we need to, so this will give you a comprehensive report of a heart rate, which is giving you maximum heart rate during sleep, minimum heart rate during sleep, whether the patient is going to tachycardia, whether the patient is going to bradycardia, or having tachyapnea or bradyapnea is happening. In this particular report, you can see the patient is having 116 times tachycardia, and total duration of tachycardias was 8 minutes 30 seconds. It's not compressed, but it is segregated in 8 minutes. That's what it's trying to tell you. And during RAM stage also, it was segregated in 2 minutes. So we come to know whether the patient is having some kind of issue or some kind of arrhythmias happening because of in ECG. So that gives you the heart rate that will come through heart rate report. It also gives you a heart rate variability report, which gives you a heart rate, which gives you better indication of heart rate, heart health. So in this particular case, if you see this example, this lot of dots density is more is here also as compared to baseline. So this particular patient was hypertensive. If you see this this average blood pressure was 146, and that is the reason it is showing you a lot of heart rate variability also as compared to the previous slide which I showed you, which has less variability. Um, so this blood pressure report, most of obstructive sleep apnea patients are hypertensive. So you need to measure their blood pressure. But how will you measure blood pressure? If you inflate a cuff, the patient will wake up. So in this particular case, we are giving you a cuffless blood pressure, beat to beat cuffless blood pressure, which gives you a whole night systolic and diastolic, both average and 15 minutes. So you will able to know how the patient has behaved and how this obstructive sleep apnea or obstructions is affecting his blood pressure. So in this particular case, we say it's hypertensive, but his average blood pressure during the day was 146. How do you define day blood pressure or night blood pressure? So once I told you, we define lights off. So we tell the patient to sleep and we define lights off. So before lights off is the day blood pressure. After lights off is the night blood pressure. So in this particular case, his average blood pressure was 146, while his night average blood pressure systolic was 127. So actually it has gone down from 146. That is why it is showing you as a dipper. Similarly, it is showing you from 77 to 69. That is why it is showing you as a dipper and non-dipper, and not as a non-dipper. It's showing you as a dipper because it has reduced, the blood pressure has reduced as compared to the day. Then it also gives you a position-wise systolic, diastolic, and mean arterial pressure. The average supine was 111 and diastolic was 78. Similarly, non-supine was 103 and diastolic was 78. It also gives you a, so it's basically non-supine is lateral positions, whether left or right. So this also gives you a comprehensive report. It also tells you graphically whether the blood pressure was increasing because spontaneously it was increasing, or because of respiratory events, or because of any other autonomic events it was increasing. So it gives you a complete comprehensive report of the blood pressure. So it tells you in the, for example, in this particular case, it tells you that it is the blood pressure changes is happening because of respiratory 121 times. So 40.6% is happened because of respiratory. So now the patient has come to you and patient is not sleeping well, or patient is feeling lethargic during the day, he's feeling tired during the day. So as a sleep clinician, we obviously look into the history, we look into the questionnaires, but once we do the sleep study, we also put the leg movements. So we do not know why sleep is fragmented. We still have not documented. So it was just an subjective measure that he was not sleeping. He is telling that he could be having a snoring or could be having an obstructive sleep apnea. But to see the objective measurement, we need to put all the sensors, and that is why we also put the leg movement sensors to see whether the leg movements is disturbing his sleep. So that is how we calculate, we see the periodic movement report. So in this particular case, you see total leg movements was 126, which includes the isolated limb movements, which is 64, and periodic limb movements of 62. If you add 64 and 62, which comes to 126 with an index of 19.9. However, PLM index is only 9, not only PLM index is 9.8. So ASM recommend if a PLM index is more than 15, we can say that it's a periodic limb movement disorder or periodic limb movement syndrome. So in this, but it also gives you PLM distribution. It means it also tells you how the PLM distribution, how the PLM periodic limb movements was there at what particular time. So if you see, it is happening mostly in this particular case. In this particular case, it's happening mostly during the early morning hours. So accordingly, if we know at what particular time movement, at what particular time the limb movements are happening, so as a clinicians, you can accordingly give the medications according to the patient. So first sleep issue is snoring. So we need to look at how the patient is, how many times the patient is snore during the night, and how many decibel levels are there in the during the night. So this gives you, this will be this will come to know through the snore report. So snore report gives you a snore index, or so it is giving you a snore of total 257 with the index of 40.9, where the prone position, he was in prone position for 107 and with the index of 35.9, and supine position, his index was 150.6. So what do you, so it is also giving you left and right and upright positions. So what do you mean by absolute snore? So total duration of snore events in each position. So total duration of snore during each position is an absolute snore in minutes. So total absolute snore in minutes was 5.3, which includes prone position, supine position, and left and right position. So that is what it is showing you, the snore analysis report. So now coming to the arousal report. So what do you mean by arousal? So what is happening? It is not in this particular case. What we saw is, in this particular case, though he has a lot of obstructive sleep, apnea hypopnea index is very high, or respiratory desaturation disturbance index is very high, it's more than 100, but his sleep efficiency was still good. It was coming around 90%. So it means he was not going into the wake stage, but he has a lot of micro arousals. So his brain is still arousing, and that is why he's feeling lethargic or tired during the day. In this particular C, if it's showing you cortical arousals and as well as autonomic arousals. So what do you mean by cortical arousals and what do you mean by autonomic arousals? Cortical arousals is changes happening in the EEG spontaneously, while autonomic arousals means it is happening because of some autonomical issues, for example, because of respiratory, because of leg movements, because of plethysmography, there is some changes happening and it is arousing the patient. So we see is showing you total arousals of 205 in non-REM and 115 arousals in REM stage, and total 320 arousal with an index of 50.6, which is actually an alarming thing, because, and that is the reason he is not able to go into stage N3, because he was getting in micro arousal and then could not go into the sleep N3, and this is high arousal index. So normal is between below 15, arousal index of below 15 is good, is okay, still okay. But in this particular case, if you see, it is showing you arousal index of 50.6, which is very, very high. So now body position analysis, as I already told you, body position analysis helps you whether the patient is in supine stage or lateral stage, and how many apneas or hypopneas are appearing in which stage. So I told you already that body position helps you, for example, in especially in mild to moderate cases, in that particular case, you can actually change the position if it's obstructive sleep apneas or obstructions are happening mostly in supine position and not in lateral position, and it's mild to moderate. You can tell the patient, instead of putting a CPAP, you can try sleeping in a lateral position, and probably this will help you in reducing your apnea hypopnea index. So now this will show you complete hypnogram, that is a complete snapshot how the patient has behaved whole night. So this will give you snore analysis, this will give you flow events, this will give you SpO2 events, this will give you cardiac events, this will give you heart rate, how this patient is behaving, this will give you a lot of obstructions, systolic, diastolic blood pressure, how the patient has gone. So this will give you a complete screenshot or snapshot, you can say. And so a lot of colorful events it's showing, because this patient is having, and as we already saw, this patient is having a lot of event happened during the night and a lot of arousals during the night. So we also, after that, we will also come to know the summary in a in one snapshot itself. Everything is red. You see apnea, hypopnea index is red. Snoring is high. SpO2 is a lot of desaturations were happening. A lot of arousals. And that is why we'll come to know this is a kind of a severe case of obstructive sleep apnea. This, then we can also have in our report interesting events. It means it will give you a lowest desaturation. It will also give you the biggest apnea. It will give you a maximum heart rate. It will give you minimum heart rate. It will also give you the maximum systolic blood pressure, minimum systolic blood pressure, maximum diastolic blood pressure, and minimum diastolic blood pressure. So it will give you again a screenshot of all the events happening, most severe events happening during the night. So now, once you have done this scoring, once you have done this scoring, and once you are giving the report, obviously you need to tell the patient this. You need to give the summary of all the what you have done. So this will give you case history, findings, diagnosis, and you also put the comments. So once you have done the scoring, you do not need to type all these things. It will automatically calculate, automatically give what has happened, whatever done manually you have already done. So in this particular case, you can see the patient weight was 126. He was quite an obese patient. His height was 171. His BMI was 42.6. So it's severely obese patient. And we saw its time in bed was 28%. Sleep efficiency was still 90.9%. But if you see, his arousal index was 102.1. So that is why he was not able to go into sleep stage N3, and he was mostly into stage N2 only. So it will also give you body position changes and how many times his blood pressure has gone up. What was his maximum systolic blood pressure was 160, for example, in this particular case. Minimum systolic blood pressure was 122. Average systolic was 144. So it gives you a complete snapshot, and then you can give this summary with comments to a patient along with that report. You can put your comments. The titration study required, patient was obese. So you need to have a titration study with the high pressures, which will help you, which will help the patient to maybe eliminate these apneas. So now we can also obviously give the titration and titration report. This is a kind of a titration report, which will give you also the pressures, and it will also give you this average pressure of the whole night. Actually, it also gives you the position wise, also the stages wise. It will give you REM stage and non-REM stage, and then you can see in which stage and in which position his obstructive sleep apnea, central sleep apnea, and how it is going better in titration. So again, it gives you diagnostic report. It gives you titration, full night titration report. You can also do a split night report where you put diagnostic in first half of the night, and once you see there are severe obstructions happening, and then you put a titration, and you would like to abolish these events during the second half of the night. So this is called a split night. So first night diagnostics and second night titration. So in this particular case, you can see the diagnosis, and you give a CPAP, and then if the If the events are not abolished for CPAP, you can always give the bi-level. If the events are still not abolished by bi-level, you can give the probably the servo ventilation and auto servo ventilation, and then you will able to see what was the sleep efficiency in the diagnosis during the therapy. So it will give you again the comprehensive report. Again, it will give you respiratory, what has happened to the respiratory during diagnosis, what has happened to the therapy, and how was the arousals in the diagnostics, how are the arousals during the therapy. Similarly, it will give you the PLM index during the diagnostic, during the therapy. How was the heart rate during the diagnostics and during the therapy. So this is how it will give you comprehensive report, split night report, and you can give this to the patient in case you're doing a split night study. You can also do the MSLT report. MSLT is what is MSLT? MSLT is multiple sleep latency test, which you do for the narcolepsy patient, which you want to for the hypersomnolence, where the patients are feeling sleepy, not because of obstructive sleep apnea, but because of some other issues like narcolepsy or cataplexy or idiopathic hypersomnia. So you need to look at how will you confirm whether the patient is having a narcolepsy or not. You need to confirm with the MSLT test. So what you need to do is you need to do a polysomnography test before in the previous night, and then you do MSLT test during the day. So this is how this MSLT report format comes. It will give you the sleep stages where the patient went into REM. So if you get the 2 SOREMs, which is this, in this particular case, you have already got the 2 SOREMs, 3 SOREMs in this particular case. So this is a kind of a confirmatory test for narcolepsy or narcolepsy with cataplexy, depending on the history of the patient. So in this particular case, you can see this time in bed. It is showing you the REM latency of 2.5 minutes, 3.5 minutes, and 2 minutes. So average REM latency was 2.7 minutes, and sleep onset latency was 0.8 minutes. So if this sleep onset latency is less than 8 minutes and you get 2 SOREMs, then you can say that it can be, or it is a confirmatory test for a narcolepsy. So in this particular case, we are getting 3 SOREMs and sleep onset latency is less than 8 minutes. So this is how the MSLT report format also can be generated. So ultimately, take home message is score the raw data correctly. Though machines also does the auto scoring, but if you are an RPHET or a certified in clinical sleep health, you should score the data manually so that you are pretty sure that what you have done is correct. Then you need to give a comprehensive report of all the parameters which I have already shown you. Like you need to show the sleep stages, how the patient has behaved in the sleep stages, whether the sleep was fragmented or not. You need to look at the respiratory parameters. You need to show the respiratory parameters. You need to show the oxygen saturation. Position analysis is important. Blood pressure analysis is important. CO2 report, though I didn't show you, but CO2 report is also important. So this is the comprehensive report you need to give to the patient in a simple way so that the patient can understand, or a clinician who has sent you the patient for a sleep study should be able to understand. And that is how the sleep report comes to the end. And this is, thank you very much. These are the 2 books I have written. If you want to learn more, you can read these books. Thank you very much and have a great evening ahead.